Hello, YouTube. All right. All right. It looks like we are live. Yes, we are. All right. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, January 25th of 2026. It is time for another live IC support group meeting. Now, I do realize that half of the United States is locked down in a horrific storm and a lot of people don't have power. So whenever I do these meetings, even though we might not have a lot of people live, sometimes we do less. Hey, listen, last week our video was seen 5,000 times, our meeting. I was like, yeah, baby. But sometimes we don't have a lot of people live, but y'all watch afterwards. And that's inevitably my goal. Hello, Melissa from Brooklyn. Melissa, I got to tell you, I was watching the live stream of the storm from New York about an hour and a half ago. And you guys are going through it. And it shocked me. Because, I come from a family of pilots. So it's very normal to watch airport streams and stuff like that. And so every now and then I put the Los Angeles airport stream on, or I put Chicago or New York or whatever. Anyway, I was looking at the Chicago stream when I got up this morning. Oh my God, it's whiteout conditions. Like, how are you flying a jetliner when you can't even see the dang runway? It's crazy. My grandfather, who was the first man to solo off the very first naval aircraft carrier back before World War II, and he was the first pilot for Walter Beach, a Beechcraft. And a rule that he nailed into my mother as my mom went through flight training is you do not fly in bad weather. And to think that they are flying jets in whiteout conditions, in heavy, heavy icing conditions, if I were a passenger, I would pass. But anyway, the planes today are a lot different than the planes, from 50 years ago and stuff like that. So Melissa said, yeah, it's brutal. Everything is closed. Man, on one hand, it's kind of amazing to watch. On the other hand, living through it's a whole nother story. And I am sure that your stress level is probably going to be pretty high tomorrow and the next day. Maybe today it might be a little interesting, and for the people whose power has gone out and it's really, really cold, and the livestock and all that, this is a big, scary storm. There's no doubt about that. Hello, Ann says magnesium citrate capsules, irritating for the bladder. I don't think so. Has anybody ever had issues with magnesium? I do magnesium glycinate every night. I tend to get a lot of leg cramps and muscle cramps. That was a joyful gift of menopause. And magnesium glycinate really helps me. So I take magnesium glycinate. And what to use for rectal itching? Proctofoam is a fabulous prescription that they can give you. It's like the best thing you can do. So you can do a Proctofoam, or you could do a steroid rectal suppository, or I love Preparation H wipes. Just it's witch hazel. It's very calming and soothing down there. And so whenever I'm having any issues down there, I bring out the Preparation H wipes, and I love it. And that's very, very good. Anne says magnesium citrate is for constipation. I don't know of anybody. At least I can't remember that. And a lot of people call. Several times a month, I'll get a phone call from somebody who's got to have a colonoscopy, and they're terrified of the colonoscopy prep. And we have a really good article on that on our website. Don't worry about colonoscopy preps. It's very, very, very rare that anybody flares from a colonoscopy prep. The odds are you're going to be very focused on something else rather than your bladder. Melissa says magnesium glycinate is fine. Donna says, hello, Donna. I'd like to try some yogurt. What would you recommend? I like Phage, Fage, high protein yogurt. Um, uh, but before I had my gallbladder removed, I did a lot of coconut milk yogurt. I tend not to do well with traditional high fat milk based yogurts, although I can do Phage no fat yogurt. It's a very thick Greek yogurt. It works perfectly for me. I had some yesterday. So Fage. Okay, so we're going to talk about treatments today. It's time to do an overview of IC treatments. And one of the reasons we're going to do this, as I explained last week, is there was last spring, this really big international meeting of 60 IC experts who came together to discuss and debate strategies on interstitial cystitis, including phenotypes, treatments, all that sort of stuff. And I have gone through their whole section on treatments, and it's missed a few things, added one thing I'd never heard of before. And so let's just dive into treatments, okay? So understand, number one, that back when I was diagnosed 30 years ago, we all believed that IC was an incurable bladder disease. Pretty much everybody was given the diet, everybody was given a low-dose antidepressant, everybody was given Elmeron under the assumption that we all had a bladder disease. Of course, now we know that's simply not true. Now we know that there are phenotypes, distinct patient groups who present very differently and respond to very, very different treatment. And as I explained in our meeting last week, this global consensus team agreed on 4 basic phenotypes with a few more to add. So phenotype number 1, Hunner's lesions. Hunner's lesions need Hunner's lesion specific treatments. Another phenotype that's also kind of in that bladder wall group is low bladder capacity. So these are patients, but again, they couldn't agree on a number value. So it's a little vague. I mean, like for me, my bladder capacity from the time I was quite young was always at like 400 cc's, 450, maybe 350. Is that low? Is that high? Yeah, they couldn't come up with a number. I mean, clearly, if your bladder capacity is below 100, we got an issue here. Your bladder is not able to hold urine. If your bladder is under 50, that is even worse. If your bladder is under 25, basically the size of a walnut, we're dealing with a severely diseased bladder wall. Okay, so again, Hunner's lesions, low bladder capacity, pelvic floor driven. 87% of patients have tight dysfunctional pelvic floor muscles, which is why we really are focusing on IC as predominantly a neuromuscular disorder as compared to a bladder wall disorder. And then, of course, we have our widespread pain group, patients who have multiple pain conditions. You got IC, IBS, vulvodynia, TMJ, migraines, fibromyalgia, etc. Now we know that that is really driven by a central nervous system dysfunction. That at some point in time, and I'm also in this group, that central nervous system was injured. It could have been injured physically. It could have been injured through abuse or bullying. But in patients who have widespread pain, we're dealing with an entire systemic issue. Now, one of the problems that we have, and I was working with the mom of a IC patient who has severe scoliosis. Okay, that went back to a really difficult childhood and some pretty major things that happened, including surgeries when she was very, very young. And just really severe scoliosis, had to have surgery. And now we're dealing with learning to live with scoliosis. I also have scoliosis, and it happened when I was 13. We don't really understand why scoliosis happens. Sometimes, it might just be that muscles aren't strong enough to support a growth spurt. There's a lot of things we just don't understand about scoliosis. So in her case, diagnosed with interstitial cystitis, and yet bladder therapies do not appear to be providing any relief at all, or very, very little relief. And as I was talking with her mom, I'm like, well, has she gone to pelvic floor physical therapy? And her answer was no, she doesn't want to do it. Understandable. Very, very understandable, because she'd been through stuff. Very, very, very difficult, painful childhood with surgeries. Our brain is programmed to avoid trauma. Our brain remembers trauma. If you associate, if I associate a doctor with trauma, are we going to want to go there? The answer, of course, is yeah, probably not. Even though we should, we probably don't want to. That role of past trauma, that medical anxiety is justified. It's not your fault. You went through something serious. I have a lot of medical trauma. I had medical trauma when I was first diagnosed with ICE. I can remember a doctor tried to do a colonoscopy without anesthesia in my 20s. I kicked him in the face as I was laying on the table with my knees up. I did. God's honest truth. I have medical trauma too. But the goal here is we don't want you to suffer. And what I need you to do is I need you to kind of step away from the concept of being ill and having a disease into being an anatomical detective. Because for us to really find the right treatment for your unique case, we got to understand your body. We don't just want to take meds. And that's the fundamental problem with how IC has been treated for the last 40 years. Is they gave you Elmeron, they gave you an antidepressant, and they sent you on your way. And some of you were on medications for decades, and now some of you have gone blind because that medication Elmeron has been associated with blindness. We don't want to chase the symptoms. We got to identify the underlying cause so we can treat the underlying cause so that you don't have the symptoms in the first place. Okay, so your anatomy matters. You have to understand and commit to understanding what your anatomy is going on with here. And with the young woman with scoliosis, what I'm hoping, if I ever get to talk to her, I only talked with her mother, is I want to inspire her to learn about how muscles change when the spine turns and you've got curves and things like that, and why bladder therapies aren't going to fix that, but there are other things that can fix that. Okay, so anyway, cause versus effect. We want to focus on the underlying cause. The way we do that is with a phenotype. How do we pick a treatment? Based upon your phenotype. And as this global consensus meeting very clearly defines, is that patients do better with specific therapies based upon their phenotype. So how do we start? Let's just say you're a newly diagnosed patient. You don't know what the hell you're supposed to do. All you know is you can't sleep at night. You can't eat the foods you love to eat. You're crying. You're exhausted, and you're desperate to find some relief. You go to the doctor, and the doctor says, okay, let's see. How do I want to say this? It's going to be really, really easy for the doctor to appease you with a pill. I don't want you to do that. I need you to start asking a lot of questions first. Like, what is the health of my bladder wall? What is the health of my pelvic floor? Let's understand a little bit more about your anatomy first before you make a decision to try a specific therapy. Right? We got to follow the data here. We're not going to guess. We have to follow the facts here. If you have tight pelvic floor muscles, you're going to need to do physical therapy. If you have a Hunner's lesion, you need to treat the Hunner's lesion. I want to say something else too. There are some patients, I was working with a patient on Friday who in 20 years had never let anybody look in her bladder. And she was suffering. And she was terrified to let somebody look in her bladder. She's like the first, I forget, something traumatic happened. Like they tried to catheterize her or something, and they used a really, really big catheter, and that was it. She was never going to let anybody touch her down there again. The reality, though, is that she was flaring terribly. But we didn't know what the flare was. Was it her pelvic floor? Well, she had been to physical therapy. They did tell her muscles were tight. She gave up after 4 treatments, but she's clearly showing signs of muscle tension because she can't pee on command. But the missing factor here is that she's got extreme bladder wall symptoms. And I said to her, listen, you're guessing. Don't you think you've suffered enough? Isn't it time to let somebody look to tell you what's going on with your bladder wall? And if you come out of that and they say your bladder wall is healthy, fantastic. Then we're going to focus on other things. But if they look at your bladder and they find a Hunner's lesion, and that's why you've been in pain for 20 years, then for God's sake, let's treat the Hunner's lesion. We don't want you to suffer for 20 more years because you got a lesion in your bladder that you've never let somebody treat because of fear. You let fear stop you, right? I have a personal philosophy here. If I'm in pain, I don't want anybody to guess. I want somebody to look at it and tell me what's wrong with it. Which is why I woke up Monday morning and we thought my pneumonia had come back from my flu. I went back to the ER and I had an x-ray, and you know what? My pneumonia wasn't back. It was asthma. Yeah, baby. Rather than stay home and guess, sometimes you need to let somebody look, whether it's an x-ray, whether it's exam, whether it's a cystoscopy, it's data, it's facts. Okay. When we start then understanding your anatomy a little bit more, there are some basic self-care techniques and tips everybody does. Because it's like we're building a house from the foundation up. You got to have good self-help skills to get yourself through this. You do. And so here, let me open up these guidelines here. Now you're all going to get a little bit mad at me, but do not get mad at me here because this is all making sense. Okay, number 1, diet. Like seriously, if you have a Hunner's lesion and you're drinking coffee every day, what do you think is going to happen? It's going to irritate the lesion. So diet matters. If certain foods are irritating you, then back off those foods for a while. Your job is to create an environment that will help your bladder heal. You don't keep pouring acid on a wound. Sometimes you have to back up. And thankfully, we've got our brand new diet guide. Here, where is it? Look, we have a brand new diet guide, literally released 2 weeks ago, that will teach you everything you need to know about the IC diet. Okay? So good nutrition is important. Number 1, fighting inflammation. Man, if you're living on a lot of sugar, what do you think you're doing? That's promoting inflammation throughout your body. It's time to walk away from the junk food and the fast food and the pastries and the candy. A diagnosis like this is a bit of a wake-up call. It kind of forces you to confront bad habits. Whether it's drinking soda every day, whether it's drinking coffee every day, whether it's eating a lot of sugar every day, whether it's smoking or vaping, you got one job here to help your body heal. Your body is in distress right now. Your body is inflamed right now. Your body is struggling right now. It's time to clean things up. Big time. And speaking of cleaning things up, we all have to understand that stress exacerbates pain. Anxiety is a logical a logical reaction to being in pain. Listen, a lot of us have had anxiety. Some of us have major anxiety disorder, but just living with pain and not understanding what's causing that pain is stressful. When you're anxious, when you're stressed, your brain interprets that as a threat to your life and it intensifies all the pain. Pain accompanied by laughter is minimized by the brain. Pain accompanied by stress is intensified by the brain. I had a patient call me right before I started this meeting who's really struggling with anxiety. And so, having things that you can do to just calm things down, especially in this crazy, sad, tragic world that we're living in right now, making sure that you're getting out and walking every day, making sure that you're exercising every day, making sure that you're disconnecting from social media as frequently as you can, because they're making money off of keeping you stressed, which is giving you more pain. We got to clean things up. I will tell you right now, I have committed to watching the entire season of I Love Lucy before I go to bed, because that's what I watched when I was a kid, because yes, I'm that old. I Love Lucy. And right now I'm on the Hollywood section and all these stars are like appearing. It's so cool, but it's so fun to just go back to the times when life was easier. So whatever show, so whether you watch Cheers, whether you watch Frasier, whether you watched Andy Griffith, whether you watch the Banana Splits, whatever, it's okay to go back and just find that joy and comfort again. Basic self-help. Recognizing when your body is in distress and being very active and informed and focusing on things that will ease that distress. Now, so this international team said IC has been associated with psycho-emotional dysfunction as well as sensation-related disturbances. We know what that is. That's central sensitization, being exquisitely sensitive. That's that widespread pain phenotype. Pain processing involves many psychological and cognitive variables, including emotions, changes in cognition, focus. I don't need to read all that. Okay, but they say something very important here. The psychological consequence of chronic bladder pain can be a sense of shame. Stop it. Not your fault. You have done nothing wrong. There is no reason for you to feel any sort of shame here. Yeah, it'd be a lot easier if it was your shoulder or your knee. Darn it, it's right down in a part of your body you don't want to talk about. But this is not your fault, my friends. Let the shame go. Knowing that you're not alone, meeting other patients is so incredibly important. Like I'm a patient. For a lot of patients, I'm the only other IC patient they've ever talked with. But I wish we had more support groups. We just don't. All the in-person support groups were pretty much shut down with COVID. You are going to find some support groups online, but they're a little questionable. And they actually say this here. They say support groups facilitated by a psychologist or an impartial clinician is of more value than one solely run by patients. And I'm like kind of halfway in between. Yeah, I'm a patient, but I have a lot of degrees and I've studied extensively and I'm a researcher also. So I have a specific psychology degree in running groups. But I am going to agree with that. Right now, the support is challenging. And every single week, I get phone calls from people who have been on a Facebook group or the Reddit group, and they're really upset and scared. And I always say, just walk away. The problem with online support groups, the way they are right now, especially in Facebook, is you can't put apples and oranges and bananas in the same group and expect success. You're going to have patients with Hunner's lesions giving advice to somebody with pelvic floor dysfunction or pudendal neuralgia. It's very confusing and scary. Okay. They strongly recommend, if you are struggling with stress and psychology and you're just really kind of like me after I was dealing with breast cancer last year, there is a point in time where sometimes you get to consult with an expert. It's valuable and valid to say, I'm not doing particularly well right now. I could use some insight on how to cope with this. And it's okay to talk with a psychologist. It's okay to go through some cognitive behavioral therapy. I've done it several times. Okay. We want to make sure you're well hydrated. We want to make sure that you're keeping your muscles relaxed and released. Just the basic self-help stuff. This is the foundation. The patients who do the best are the patients who embrace self-help. You have a lot of control at your fingertips at home every single day. Your choices can either help or hurt how you're feeling right now. So it's time to embrace the things that potentially are going to help more. Again, like a good, healthy diet, managing stress, getting out and walking, all that sort of stuff. Okay, let's go to actual therapies. So the first thing we're going to talk about is pelvic floor, because that's the first thing that they talked about. Hypertonic pelvic floor muscles can exacerbate pain and urinary urgency through peripheral and central sensitization. Pelvic floor therapy is recommended for patients with high tone pelvic floor and pelvic floor centric pain. It can be performed either alone or in combination with some other treatments, like, for example, a trigger point injection. If you know what a trigger point is. A trigger point is a muscle knot. So if you've ever had a trigger point in your back, what do you normally do? It's like you go find the nearest family member and say, push here, please push here, please. And if you rub that trigger point, the muscle will release. Let me give you a picture of a trigger point. So as long as there is a trigger point in a muscle, we are dealing with a screwed up muscle. It's very, very important that if we find trigger points, we release the trigger points. And I'm going to show you a picture why. Here, hold on. I was just showing this to somebody a couple days ago. Okay. So understand that, muscles are amazing. And so the way muscles work is you have muscle fibers. And the muscle fibers generally are kind of relaxed and released. But when you need to tighten them, the muscle fibers slide together, just like this. And then they lock down. There are little fibers that connect the fibers. So now we've got a strong muscle. And then when it's time to release that, normally the muscles release. There we go. And now we've got a nice relaxed muscle again. But sometimes they get stuck here. They get stuck. That's a trigger point. Okay, so let's look at a trigger points. Here you go. So you can see from these two pictures that when you have a trigger point, it gets so big, it compromises blood flow. So now we have diminished blood flow on the other side of that trigger point. And over here, over on this side, it also has the potential of affecting nerves. So one of the big parts of pelvic floor physical therapy is that they are going to look for trigger points. And if they find a trigger point, they're going to treat it. They're either going to rub it. They might teach you how to rub it with a wand, but sometimes they have to do trigger point injections. So the injection typically contains a local anesthetic with or without a steroid to interrupt the pain signals. And the goal there is to try to get that trigger point to relax and release. And as they say here, the procedure's success depends on accurate identification of trigger points. Okay. Anyway. We also now are entering what we call the low intensity shockwave therapy treatment. And I will confess that I just don't know that much about the low intensity shockwave. We have a number of doctors that are doing it. Ken Peters, who is one of our top IC researchers in the world, he is using a variation of it up in his clinic in Michigan, and he raves about it. He believes that it's really, really helpful. So so that's also very, very interesting. Okay. Now, what about a cystoscopy with hydrodistension? Now, that was often used as a treatment 10, 20 years ago. So the theory behind a hydrodistension is that you stretch the bladder with water under pressure, which then stretches the bladder, hopefully to help it hold more urine. And that's kind of diagnostic. That's one of the ways to get a really clear look at the bladder wall to see if there's any funkiness happening with the bladder wall. But what happened when they invented this technique is that some patients felt much better after having a hydrodistension. And they started thinking of it as a treatment. Well, maybe this can be a treatment. And in fact, today, when it is used, it is really more often used therapeutically as compared to diagnostically. So how does a hydrodistension work? Well, it turns out when you stretch the bladder, you break the nerve. You're just breaking the nerves. Okay, and that's why people feel better for several weeks after having a hydrodistension. The problem is the nerves always grow back and the pain comes back. That is what I call a destructive therapy. That is working by destroying something, but it's not permanent. It always comes back. So what do they say here? Let's see here. They say cystoscopy can be used as a diagnostic and therapeutic intervention. It allows the doctor to look for Hunner's lesions. It should be performed at a low pressure only for under 5 minutes. And that's a way of assessing bladder capacity under anesthesia, and it will allow them to treat a Hunner's lesion if they find it. There are some patients out there, including my former very, very good friend Donna, who has since passed away, who said only hydrodistensions helped her, and she would have a couple a year. The problem is that every time you have a hydrodistension, you go under anesthesia. And every time you do that, we are multiplying the risk of anesthetic-related complications. Hi, Bonnie. So you guys keep asking your questions. I will come back to them, okay? Okay, now let's come to oral therapies. So again, we have our phenotypes. So how are oral therapies going to help specific phenotypes? Well, Elmeron, also known as pentosan polysulfate, acts to coat the bladder wall. Okay, and as they say here, it's the first medication approved by the US FDA, and that's now pretty questionable, in all honesty. We have a big blog called The Trial and Tribulations of Elmeron over on our website that talks very specifically about what happened as it was going through FDA approval, that the FDA rejected it for 5 years, because the research they gave only showed one doctor using it successfully. Every other doctor failed. And then mysteriously it was approved. And that study that the FDA asked for was finally done 18 years later, and it showed it didn't work for the great majority of patients. And pretty much the doctors who did that study that was released in 2015 thought it would be pulled from the market. We all thought, it should have been pulled from the market, or it could have been pulled from the market. It's still out there, which is, in my opinion, quite shocking. One of the things they say here is recently concern has grown over the long-term use of Elmeron because of a possible induction of pigmentary maculopathy and visual impairment. And they cite specifically greater than 13 years. But if you look at the black box warning on Elmeron, it is 3 years. It is not 13, it is 3 years. And in our study of over 2,000 patients, our survey, some patients had vision changes in their first year. And that isn't even talking about the bowel issues that they're now tracking with it and the inflammatory bowel disease. So, Elmeron is In the old AUA ranking system where they ranked based upon the risk of adverse events, it would have ranked as one of the end options rather than an early option, just because of the risk of eye disease now, eye damage. Amitriptyline. Oh, and by the way, the last sentence on Elmeron pentosan polysulfate is clinical trials have reported conflicting results with no significant differences in symptoms between Elmeron and placebo. So what does that mean? It means that it isn't showing success in some clinical trials, specifically the 2015 clinical trial run by Curtis Nickel. So they specifically mention this in this international group. Amitriptyline, let's go to the low-dose antidepressant. Now, a low-dose antidepressant is often used for chronic pain disorders. It acts by calming nerves down. So what they say is amitriptyline is a mainstay of treatment for many chronic pain disorders, including IC. Achieving a dose of 50 milligrams a day increases efficacy. Unfortunately, there are many potential adverse events associated with this medication: dry mouth, dry eyes, weight gain, and irregular heartbeat, which is what happened to me. It can change your heart rhythm. However, they say if you combine amitriptyline with alpha lipoic acid and polyunsaturated fatty acids, this reduces the necessary amitriptyline dose needed and decreases potential adverse events. I have never seen this written anywhere. So I want to learn more about this. I've never seen this before, but we have a paper on it. Let me look at that real quick. What was this paper? A 2017 paper, alpha lipoic acid plus omega-3 fatty acids for vestibulodynia associated with painful bladder syndrome. Okay, we'll have to look at that a little bit more. Okay. The fundamental problem with amitriptyline, though, aside from the side effect profile, is it is an anticholinergic medication. Anticholinergic medications have now been linked to dementia and cognitive decline. And so kind of the rule now is people are stepping away from anticholinergics, especially the long-term use of anticholinergics to protect your cognitive function. And generally, anticholinergic medications usually not recommended for somebody over the age of 60. But there was a study that tested the impact of medications like this on people in their 20s, and people in their 20s started showing cognitive decline. Okay, so there are consequences to using anticholinergic medications like amitriptyline every single day. Another medication that they can use is an antihistamine called hydroxyzine. Hydroxyzine helps to stabilize mast cells, and they say it is particularly useful in patients who have systemic allergies. So if you are, and I remember, I was having lunch with, before we did our big IC conference years ago, and I was sitting with one of the top IC researchers who was a guest speaker, and he looked at me and he goes, "Do you have allergies?" And I went, "Yeah." And he goes, "You should try this medication, hydroxyzine. We don't really understand why it's helping, but it is helping a lot of people." And you know what? I tried it and it helped me. They say dosing should begin at 10 milligrams and should be titrated up to 50 milligrams. I think that would be a lot, because hydroxyzine is actually sedating. I don't know how you would do that. You wouldn't normally take this medication in the morning because you'd be sleepy all day. At least I was sleepy when I tried taking it in the morning. I only took it before I went to bed. One of the benefits of hydroxyzine is it has what we call a beneficial side effect. It has an anti-anxiety effect. So I actually took, I couldn't take 25 milligrams. That was too high for me. And they had me cut the capsule in half, and I did 12 milligrams. And I did that for several years. And did it cure me? No, because now we know my bladder was healthy and I had pelvic floor. Did it chill me out? Yes. Is it an anticholinergic? Yes. So I consider myself a little lucky that maybe it affected my brain function a little bit. I don't know, but I took it off and on for about 8 years. Okay. And as they say here, to manage potential side effects of sedation or weakness, patients should take the medication before bedtime. Actually, generally, the challenge with hydroxyzine is it's a little bit harder to wake up in the morning. I felt like I had to push through an extra layer of sleep before I was actually able to wake up. But once I woke up, I was fine, and I was fine throughout the day. But taking it at night made it a lot harder to wake up in the morning. Whereas if I took it at dinner time and I didn't have to go anywhere, and it was in my bloodstream for a good 10 hours before I needed to wake up, that seemed to be better. Okay, here's a medication that I just don't have a lot of experience with. I haven't seen a lot of its use here in the United States. It's called Silodosin. So a possible relationship between IC and the sympathetic nervous system is investigated. Sympathetic nervous system is what drives fight or flight. We know fight or flight is very common in patients with widespread pain. It is a highly selective alpha-1A adrenoreceptor with a safe cardiovascular profile when used for benign prostate hyperplasia. They say improve bladder pain and urinary frequency in up to 60% of IC patients. You know what? Hold on a sec. Maybe I'm just being an idiot here and I'm just not. Let me look at the brand name. Silodosin brand names. I know that this was never, no, Rapaflow. Yeah, it's a medication used to treat and enlarge prostate for benign prostate hyperplasia. So it's interesting that this IC group mentions it. Again, I have no experience with this at all, nor have I worked with any other patients who've used it. They also mention urinary analgesics, acetaminophen, opioid and non-opioid medications, as well as muscle relaxants. So if you've got pelvic floor dysfunction, doing a muscle relaxant could be really helpful, like Flexeril or Baclofen. But muscle relaxant is not necessarily going to help widespread pain. Okay, the next thing that they're talking about here is immunotherapy. Although the underlying cause of IC remains poorly defined, some data suggest a correlation with an aberrant immune response. Therefore, controlling or modifying the intravesical immune response can be beneficial. In other words, kind of an autoimmune dysfunction potentially. So they talk about cyclosporin. Cyclosporin, which is normally used in organ transplantation and in autoimmune diseases, has gained attention for treating severe refractory IC, particularly in patients with Hunner's lesion. It suppresses T-cell mediated inflammation, which is implicated in the chronic inflammatory state of the bladder wall. Cyclosporin reduces immune activation, potentially alleviating pain and urinary symptoms. And there are research studies that show cyclosporin being effective in patients with Hunner's lesions that are not responding to other therapies. It is not as effective in patients without Hunner's lesions, so suggesting a phenotype-specific benefit. In other words, if you got the Hunner's lesions, that's the door that's going to be used, Jen. If you don't have Hunner's lesions, not going to be as effective. Here's a study done at 3 centers, reported an 85% response rate in 34 patients with Hunner's lesions, although almost 20% had to discontinue it because they had severe adverse events like high blood pressure and elevated creatinine. So Hunner's lesion, I have heard some doctors talk about Hunner's lesions as being a bit of a miracle drug for patients with severe Hunner's lesions that haven't responded. Uh, your urologist is not going to administer that therapy. You're probably going to be sent to a rheumatologist or a different type of doctor who is going to monitor that more carefully. You have to understand that there are pretty significant risks associated with this medication. Therefore, this is not a casual decision. You got to have a really good, clear understanding of what the risks versus benefits are when you go in to talk to the doctor about that. So you got to do your research ahead of time. Okay. What about steroids? Can steroids be used? And the answer is no. They're not recommended for IC due to a poor risk-benefit ratio. Oral steroids, however, steroids have been injected into a Hunner's lesion with success. All right, now bladder treatments. What about bladder wall instillations? Intravesical instillations play an important role in a combined treatment regimen. They are particularly useful in patients with bladder-centric pain and patients who have painful flares, bladder wall flares. This is where a drug solution is directly administered into the bladder using a catheter or a little syringe adapter. The goal of an intravesical treatment, a bladder installation, is to directly reduce bladder wall inflammation, pain, irritation, and to perhaps help with the regeneration of the gag layer and long-term symptom control with maintenance relief. But see now, think about that. Long-term symptom control. So in other words, it's not fixing anything necessarily. It's all about helping you manage your symptoms. And again, that's a mindset that listen, there's nothing wrong with that. If you're in pain, you're having symptoms, you need to be treated. But we also need you to try to focus on underlying causation. Christine here on YouTube says, I'm going to bite the bullet and try pelvic floor therapy. You go for it, girl. Go for it. I have a really good video on physical therapy over in our IC 101 masterclass. It's free on our website. Okay, so what are the advantages of installations? High local drug. I mean, here's the fundamental problem here. You guys, the fundamental problem with having a bladder problem is how do we get the medication to the bladder? Right? Because y'all have digestion. We have digestion. When you take an oral med, it's not like all that medicine arrives in the bladder to do what it says it's going to do. Metabolism occurs, digestion occurs. The bioavailability of Elmeron, for example, was tested at roughly 8%, which meant that 92% of it is destroyed by digestion, which is why people had to take a lot of it over time to get a beneficial effect in the bladder wall. So when you swallow a medication, how much of it is actually going to get to the bladder to be helpful? Not a lot. The bioavailability of chondroitin, for example, is much better. That's at, I think, 25%, which is why the chondroitin-based supplements are really quite popular. Okay. The advantage of a bladder installation is 100% of the medication gets to the bladder wall. It gets to the target tissue. The problem with that is you pee it out, so darn it, you get the medication in there. It's like, oh, it's there. They numb your bladder with some lidocaine, but eventually, listen, you're not going to be able to hold it for 24 hours, nor should you. You shouldn't hold it for an hour. We call that dwell time. Dwell time is roughly 20 minutes. There have been some medical devices invented. God, whatever happened? We had what was that called? It was called the lidocaine pretzel. And then a big company bought it. It's basically, they had a little tube that they put into your bladder that had medication in it, and it would slowly release medication for 2 weeks. Man, what was that called? The nickname for it was the lidocaine pretzel. Anyway, a small company developed it, and then a big company bought it, and I think they're using it in chemotherapy. Okay, so, or in another way. But again, you get my drift here. It's hard to treat the bladder. Orally, it's ineffective. With a bladder installation, yeah, we can get the medication in there, but darn it, you pee it out. So this is not an easy fix. It takes time and consistency to help calm the bladder wall. Okay, so what's the advantage? You get a lot of medication in the bladder exactly where it needs to be. You don't get the systemic side effects like weight gain and nausea and things like that. It can immediately reduce pain, urgency, frequency, and it can actually be used to diagnose a bladder-centric problem in the first place. Because if they put lidocaine in your bladder and it turns all your symptoms off, then okay, we know we're dealing with a bladder wall issue. But if they put lidocaine in your bladder and it numbs your bladder, but your symptoms are still there, then that means that we're dealing with something outside the bladder. The challenges with catheterization is that they cause discomfort, and it's specifically in the urethra because you're stretching the urethra. Everybody has ever had a bladder installation. I probably had 20 in my lifetime. You know, the first time you try to pee afterwards, the first couple of times you try to pee, it is not fun. Your bladder, your urethra has been stretched, and you're sitting there on the toilet going, you're just like, oh my God, can I do this? Can I do this? Because that first time you pee is very, very painful potentially. I just learned as a kid, because I was doing all this when I was 13 years old and 14 years old. I had to bite my lip and just let it fly. Thankfully, that urethral pain does improve after a couple of times. Another issue is that you're at greater risk of infection, because anytime you put something up your urethra, you have the potential of introducing bacteria up into your bladder. The medication can be very, very expensive. You might need a lot of doctor visits, which can be very, very expensive. And of course, it might not work. So what are the bladder installations that are commonly used? Well, DMSO is old school. It's kind of like a legacy treatment. DMSO, dimethyl sulfoxide, is actually a byproduct of the paper industry. They thought it was going to be a miracle drug. They discovered it back in the 1950s when they were trying to find something that they could store a kidney in that they were saving for transplant. Because if you put a kidney in ice, the ice crystals destroy the kidney. And someone somewhere, I think it was Alfred Globus, I think it was his name, is the guy who discovered that you could use this chemical derived from paper processing to kind of protect and store an organ while it's being put on a plane and sent somewhere else for a transplant. And so they thought back in the 50s that this was going to be a big miracle drug that was going to help a lot of medical conditions, including IC. Every single study failed but the IC study. And the IC study was, like this kind of effectiveness. And so that's why DMSO got approved by the FDA. And I actually interviewed Alfred Globus, who wrote the FDA materials for that. And again, they really had hopes that it would be a miracle drug. Turns out it wasn't. DMSO has anti-inflammatory, analgesic, and muscle relaxant effects. However, it can cause bladder irritation, a garlic-like odor on the breath, and pain and discomfort. Now, I had at least 8 DMSO treatments myself. They did nothing for me. The worst mistake I made as an IC patient was trying to drive home with DMSO in my bladder. Don't do that. Take my word for it. If you're having any bladder therapy, you stay at the doctor's office for that half hour, and then you pee it out, and then you go home. Okay? Don't make the mistake that I made. And as this international committee says, there is no consensus on the dose, duration, or the number of treatments needed. So DMSO has fallen out of favor. It's just not used as much. It's a penetrant. It helps to get through the bladder wall fairly easy, but the data is very, very mixed and uncertain. And as they say here, there's just no consensus on what the dose should even be. Okay. So what replaced it? Lidocaine. and heparin, but lidocaine is a numbing agent. It's an essential ingredient in what we call a rescue installation because it will rescue you out of a flare. How does it do that? It numbs the bladder wall. So when you get lidocaine put in your bladder and you're having a bladder wall flare, the pain should turn off and you should walk out of that doctor's office pain-free for several hours. That's the goal. But of course, it wears off. But patients much prefer having an anesthetic installation as compared to doing a DMSO installation, which is can be quite painful. They are, so what does he say? A solution of 2% lidocaine may provide immediate pain relief and reduced urgency frequency. Lidocaine is particularly useful in icy flares. And alkalinized lidocaine increases efficacy by improving absorption into the bladder wall. So what does that mean? It means that doctors generally do what we call a cocktail. A cocktail isn't just one drug, it's multiple drugs in the installation. And so most common installation that you're going to find today is heparin to coat the bladder, lidocaine to numb the bladder wall, maybe a little bit of a steroid in there to reduce some of the inflammation. Some doctors like to add a little bit of an antibiotic in there to kill any infection. And they always are going to do a little tiny bit of sodium bicarbonate to alkalinize it because that improves absorption. Okay, but here's the rule. There are patients out there who do these installations at home. You never, ever, 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 ever add more of anything to the formula. If you add more lidocaine, you could overdose because lidocaine improves absorption. So for any home bladder instills, you always, always, always follow the directions. You do not get creative. These are medications that have dangerous side effects. Okay, and I have to clarify something here because, I mean, come on, I've been doing this for 30 years. And one of the blessings of being a perpetual student and one of the blessings of going to graduate school, anybody who's gone to graduate school, you're humble very, very quickly because you realize for every question that gets answered, there's 100 more questions that need to be asked. And anybody who thinks they know everything is wrong. I mean, there's just so much we're learning over time. So when I think, and also understand too, that, and we call this basic bladder studies, there's a lot about the bladder we just don't know. I mean, this is why a lot of our IC research money has gone to basic bladder studies. I mean, like, how does urination happen? What triggers what, which triggers what, which allows you to pee? Is there a chemical cascade there that triggers that? The gag layer is very, very interesting. The glycosaminoglycan layer, and let me get my slide here. Hold on a sec. Okay, so this is an old Elmeron postcard. They don't use these anymore, but it happens to be a really good educational tool. So this is kind of a three-dimensional picture of your bladder wall. And of course, your bladder wall is not blue. The color's here to help you understand the different layers. So we have on the inner surface of the bladder wall, we have the gag layer, and it is a barrier. It protects the urothelial cells. These are the cells which, are the basic structure of the bladder wall. That's your skin. So this is a mucous membrane, just like your mouth. Your mouth is wet and slippery. So is your bladder wall. The gag layer is a wet and slippery layer. So when I think of the bladder wall, it is, the way I interpreted it is that it was hydrophobic, that it pushes water away, it pushes urine away from the cells. But I learned something here. I'm wrong. What they say here is that the gag layer is hydrophilic. It binds water. It pulls water and forms a molecular layer of water at the bladder surface, which then acts as a barrier. So I'm going to have to read a lot more about that, because I always thought it was the other way. I tend to think of the gag layer as being like mucus, because it is mucus. So I haven't seen it written like that before. So I got to learn a lot more about that. But anyway, the point they're trying to make is that for some of us, the gag layer has been disrupted, whether the bladder has been damaged in some way. And of course, when that happens, urine now gets where it's not supposed to be. Urine gets down to the urothelium. Urine gets into the center of the Hunner's lesion. And this irritating urine causes massive inflammation. And these cells are not passive cells. When there's an invader, and urine is an invader, man, they trigger your immune system to come and help and try to figure out what's wrong here, right? So the goal here now is to try to repair this missing area. And that's the way Elmeron was developed. Pentosan polysulfate was developed as an oral medication that would coat the bladder wall. And again, one of the flaws of Elmeron is that it's very poor bioavailability at 8%. So instead, we can put a medication directly into the bladder where 100% of the medication arrives to coat the bladder wall. And that includes heparin, which has an anti-inflammatory and superficial protective effects that reduce hypersensitivity, pain, urgency, and frequency. Or chondroitin sulfate. They can put liquid chondroitin in your bladder wall, in your bladder. That is called Uracyst. Not available in the United States, available everywhere else in the world, but not the United States. So chondroitin sulfate acts as a protective barrier, preventing irritants in urine from penetrating the bladder wall and causing inflammation or pain. It also has anti-inflammatory properties and is particularly effective when used with another coating agent called hyaluronic acid. That's known as cystostat when used by itself, or if they combine the two, it's called Ialaril. And so this is where patients in Europe and Canada have a tremendous advantage over patients in the United States, because we do not have access to these meds. And of course, they talk about Botox. But they don't say a lot about it, which is interesting. Sacral neuromodulation, using electricity to try to remodulate nerves, is also possible. So neuromodulation uses electrical stimulation to modulate nerve activity and alleviate IC symptoms. Sacral neuromodulation targets the S3 nerve root, which influences bladder and pelvic floor function. Pudendal neuromodulation targets S2 through S4 and offers a more direct approach to pelvic innervation. The results are in the research studies are I'm not going to say quite good, but they are good. However, the risk of adverse events are quite high comparatively if you look at the FDA database. The FDA database, called the MOD database, usually adds about 500 serious adverse events a month for patients who do InterStim, as an example. And so while they like to kind of make it look easy peasy, when you actually look at the data and you look at thousands of adverse events filed from patients who have had MRSA infections, devices breaking, devices moving, patients getting shocked when having bowel movements, patients getting shocked when going through security portals like at an airport or at a courthouse. And there are actual fatalities associated with neuromodulation, specifically InterStim. The last time I looked, which was last year, a fatality occurred in December 2 years ago of somebody who had InterStim, developed an infection, ends up at the hospital. The doctor who implanted the InterStim long gone, and the doctors at the hospital had no experience with it at all. And they had to reach out to the company, try to get some help because this patient had a life-threatening infection associated in some way with this surgery, and the patient did pass away. So if you're considering neuromodulation, I have a huge section of it on the IC Network website, including a series of questions that you want to ask your doctor. This is not something, you do not want a newbie doctor. You don't want to be their first 10 patients doing this. You want somebody with a lot of experience because it's working around very, very delicate nerves, and the side effect profile is pretty concerning, in my opinion. All right, what's new? What's coming up that's new? Monoclonal antibodies. The TNF antagonist certolizumab has demonstrated significant symptom improvement, particularly in patients with moderate to severe IC. But they have to do more clinical trials to prove that it's safe. So that's coming. Here's another one called gefapixant. It's been found in randomized double placebo-controlled study to be safe and effective for IC. And there are several that were not found effective, like AQX1125, which was something that we all did clinical trial stuff on a couple years ago. They're talking about hydrogels. That's interesting. Putting a gel-like substance into the bladder with various medications. That's in development. And the use of liposomes, little hollow spheres filled with medicine that have an oily base on the outside. You put them in the bladder, the oil helps it pass through the bladder wall. So we have had some research with liposome-delivered therapies for about the last 10 years, but nothing has come to market yet. And so that's pretty much it. That's pretty much it. So to summarize, you start with the basics. You got to buckle down, do your self-help. You have to. You just have to. If you're struggling with anxiety, we got to work with the anxiety. If you're struggling with diet, we got to work with the diet. We got to work with water intake. I mean, there are some patients out there who don't want to drink water. They say they get nauseous with water. Well, you got to get your fluid somewhere. The bladder needs water to dilute urine so urine's not so irritating. So you always start with self-help. And then based upon your phenotype, that's what drives your treatment. So if you've got Hunner's lesions, you're going to do Hunner's lesion specific therapy, specifically laser therapy, fulguration, or steroid injection. And of course, we now have the over-the-counter supplement lactoferrin, which was found in one study to be helpful with Hunner's lesion. If you've got bladder wall-driven symptoms, then we're probably going to do bladder wall-specific therapies, maybe like the bladder installation. If you're pelvic floor-driven, as 87% of us are, man, you need to get your tush to physical therapy. And if you've done it 4 or 5 times and it's not helping, you have to ask the physical therapist, am I getting better or are my muscles always locking back down into tension? If your muscles are always locking back down into tension, we have to figure out why. Don't give up on it. Ask different questions. A lot of people with tight pelvic floor muscles. I was working with a patient with left side pain. She's like, it's my bladder. I went, no, it's not. It's not your bladder. Your bladder is not down by your left hip bone. That's something else. We got to figure that out. And then she said it turned out that she had been diagnosed with a doctor with a hip problem. Okay, that's playing a role in her symptoms. And if you've got the widespread pain phenotype, bladder therapies are really not going to be that successful because your treatment has to focus on calming your central nervous system down. That's where we're going to do systemic therapies like the amitriptyline, like the PEA. Because this obviously didn't go over supplements. I have our free IC 101 masterclass. We go into treatments in depth and phenotypes in depth. And again, there's a lot of debate about what are the phenotypes. Chris Payne believes there's 5. Curtis Nickel, the top IC researcher in Canada, believes that there's 9. AUA believes that there's 3. This group believes there are 4. Doesn't matter. Doesn't have to be perfect. The point here is we just have to start focusing on identifying underlying cause. You might have a fibroid tumor pushing on your bladder. That's possible. You might have posterior fornix syndrome. You might have one leg longer than the other. You might have a broken tailbone. You might have endometriosis. You might have fibromyalgia. Those are all big clues. And for anybody out there who's just doesn't quite get it, or if you've been on bladder therapies for years and you're just not getting better, that's when we stop, take a step back, revisit the diagnosis, and try to understand what your phenotype might be, because they just might have missed it. All right. Obviously, I can talk forever. Hold on a sec. Let me get a drink. Okay, let's do questions. Now, you guys, here's my rule. Please be a squeaky wheel. Don't be offended if I miss your question. Just ask again. Okay, just ask it again, because it goes by really quickly. So hold on a sec. Let me scroll back here. Donna's, okay, hold on. Hold on one sec. Now, again, Facebook always messes with me because it jumps all over the place. So bear with me here. Oh, come on. Melissa says, I only drink water and my diet is super strict. If I don't follow it, I'm flaring. And which new diet guide? So the diet guide's over in the IC Network shop, right on the front page. You just click on the link and you can see the diet guide and the flare guide and the original book. Melissa says she agrees about the role of stress and anxiety. She says, you're literally telling my story. Robbie says, I find it impossible to be anxious if I consistently practice gratitude. I make myself thank God for certain numbers of things from my day every night before I go to bed. And that really helps my anxiety. Robbie, thank you for sharing that. That's fantastic. I don't know. I have a lot of medical anxiety right now because of going through breast cancer surgery. And I was seeing my surgeon, because my incisions are so painful. Even now, a year later, I still have so much pain right here. And I just love my surgeon. And she just immediately makes me feel better just seeing her. And I just said, listen, I'm so grateful that you guys saved my life. And I'm not here to blame anybody for what happened. I just want to try to understand what's happening. What can we do to reduce some of this pain? And she's like, so if I'm treated with respect and kindness, I do well. If I'm treated with hostility, man, that definitely tweaks my anxiety a bit. And also too, just I have my rule. So I learned this in my 20s, that if something was really bothering me, or let's just say you have a mole and you don't know if it's cancer or not, and you don't want to go to the doctor, and it's but it's there, and you keep looking at it, for a week, 2 weeks, 3 weeks, and you start to worry about it. And then a month goes by, and then 2 months go by, and then 3 months go by, 6 months go by, and you're worrying, maybe that's cancer. Maybe I have cancer. And I've seen this actually with some cancer patients. I was working with one patient who had a walnut-sized tumor that she could feel in her breast. And she still hadn't gone to the doctor out of fear. But what if it's cancer? And I'm like, well, what if it's not? Come on. The earlier you catch stuff, the easier it is to treat. Anyway, so eventually I get to the doctor and you go, oh, no, that's just an age-related spot. You just played tennis. And it's like, I just spent 6 months worrying unnecessarily about something that was not a problem. And so I learned really quickly that if I was worried about something, especially with my health, just go to the damn doctor. Don't sit there and wait. Just call, make an appointment. You can do, and we've got these video calls. You can just hold it up to you can hold up whatever to the camera. You can send email, but just don't allow yourself to sit and stew at home and worry and worry and worry and worry. Okay. Robbie says, shame is very isolating. I hope it doesn't contribute to dementia. Yeah. Well, they say that people who have good family support and friend support do better than people who are isolated. And I think that that's something that we all have to work on. I walked today, I talked to people today, I helped an elderly lady who was getting out of her car. You can't sit at home. That's why it's important you get out and you just, when I walk around the lake, I just say hi to everybody. Good morning. Good morning. Nice to see you, And then occasionally you'll have a good conversation with somebody and just let your soul shine, let your spirit shine. Donna says, very true about support groups. Too much advice from other patients on support groups. Yeah. Anne says, I learned so much from you. Thank you very much. You're welcome, honey. Hello, Bonnie. Debbie says, oh my God, needed you today. How are you? Went for an MRI. Have a bulging disc with a tear. Also a facet joint cyst. Is this my trauma causing my bladder to go haywire? Would amitriptyline help? Amitriptyline would certainly calm some of those nerves down from that bulging disc potentially. But, PEA might be a first line step. The palmitoyl ethanolamide supplements like Peora or P-Leaf would be an entry point to that without the risk of the side effects that the amitriptyline comes with, because amitriptyline is a really hard medication to tolerate. And doctors talk about it in meetings. They say like the optimal dose is 75 milligrams, but they also say it's almost impossible to get a patient up to 75 milligrams without adverse events. And one patient that I was working with had gained 50 pounds on amitriptyline. It's rough. Anne says it's the gag layer with the mast cells. No, the mast cells are underneath the gag layer in the urothelium. Michael says, instillations burned your bladder. Any other suggestions? Michael, it depends upon what your phenotype is. And I'd also really like to know what installation they did. There are some old installations like chlorpactin and silver nitrate that deliberately burned the bladder wall. We called them bladder stripper. The theory behind them was to strip off the entire bladder lining with the hope that a new whole bladder lining would grow. Of course, we don't do that anymore. That's not even mentioned in our guidelines anymore. That's what they did 40 years ago. Charito said, that's what happened to me. I was laying when they put the meds on me. After halfway done, it all came out. Yeah, it can happen. Paula says, hello. Hello, Paula. Queller says, I went for a spinal cord stimulator to reduce pain and take less medications and to be functional without excruciating pain. If it works, hon. It's just, there's a difference between a spinal cord stimulator versus InterStim or a, pudendal nerve stimulator or sacral nerve stimulator. So, you kind of have to be specific on what exactly they're choosing to do. Listen, pain is suffering. I'm against suffering. I suffered horrifically for the first couple of years of my IC. I had no pain care. I had nothing. It took a year before I even got pain medicine. And I was crying. I would literally be up most of the night and I was working and I'd be laying on my living room floor praying to God to fix it while I was running to the bathroom. And the minute we were able to turn off my pain with a pain med. I was stunned. And I'm a pharmacologist. My first training, my second degree is in drug development pharmacology. It never dawned on me to use pain meds. So I'm not for suffering. I know that suffering is horrific, and I have suffered. And I know that many of you have suffered. But you can't just go to pain care. You can't just depend on pain medicine, as some patients have done. You got to ask, why am I in pain in the first place? What's causing the pain? So if you go to a pain clinic, which many patients have done, understand there are two different types of pain clinics. There are pain clinics that are kind of detox to get you off of pain meds. And then there are other pain clinics that are sincere pain clinics that will try a combination of therapies, and including, if necessary, pain medicine, but they're going to focus on an underlying causation. And so if you have an untreated Hunner's lesion, that's going to be really, really painful. Well, let's treat the lesion. Let's not take pain meds for the next 30 years. Let's treat the damn lesion, and maybe the pain will turn off. If you've got incredibly tight pelvic floor muscles, let's do some physical therapy. Muscles respond beautifully to physical therapy. If you've got a giant fibroid tumor pushing on your bladder and your doctor said, maybe we should remove that surgically, and you said, no, maybe we do need to remove that surgically. Maybe that's what's causing your pain. As happened with the patient I was working with 2 weeks ago. Cause versus effect. Treat the cause, my friends. Laura says, I have Hunner's lesions, and it seems that cystoscopy with fulguration helps best for me. I tried to take Elmeron for a year, but I couldn't tell that it made a difference. It wouldn't, honey. It wouldn't have made a difference, because a Hunner's lesion is profoundly different. I have pictures. Here, hold on a second. I mean, we've known, at least I've known for years, that patients with Hunner's lesions didn't respond to Elmeron therapy. I don't think I ever talked to one. And I don't know of any study that has ever found a bladder coating effective for a Hunner's lesion, because a Hunner's lesion, here, let's see. So these are lesions. I mean, these are big bloody wounds. They might be small wounds that when you stretch, they bleed a lot, but a Hunner's lesion is then they often have, as you can see here, a red center. We call that a coagulum. So what is this? This one is inflamed Hunner's lesions, inflamed lesion with neovascularity without the stellate appearance. And then let's see, what's this picture? Okay, here are more Hunner's lesions, and Hunner's lesions, a lot of Hunner's lesions, again, tend to have these red centers. And when you biopsy these lesions, you find massive inflammation. So deep in the tissue, there's like a biological war happening. It's significant inflammation. And so the way they treat a lesion is they're going to inject a steroid into it to try to calm some of that inflammation. They might cauterize the lesion to close it so urine's not going into it. But one of the enduring mysteries in IC is what causes a lesion in the first place anyway? And there are like 3 theories here. The theory number 1, it's supported by research, is that for some patients, there's a virus at the center of the lesion, that it's a viral infection, specifically Epstein-Barr. And what's interesting is it was the European IC research community about 15 years ago who were the first they were comparing the urine of patients with lesions versus patients without, and they kept finding virus in patients of lesions that they didn't find in patients without lesions. And they produced multiple studies that identified viral infection. Now, we are all sitting here. I mean, you go back, you can watch my support group meetings back then. It's like, we're waiting for the Americans. All right, guys, here's somebody who has a genuine cause for a Hunner's lesion. Do you have any comment on that? What do you think of that? And the Americans were very, very quiet for 5 years. And it turns out that the MAP Research Network, which is our big National Institutes of Health, IC, and chronic prostatitis research team, they were doing their own viral study for years. And they had urine samples, hundreds and hundreds of urine samples from patients over time. So they went back and they looked at those urine samples. And you know what they found? Virus in about 5% of IC patients. What percent of patients tend to have Hunner's lesions? 5%. So the Europeans found it, the Americans found it. The problem is, how do you treat a viral infection? We had a couple of small studies that have been presented at big annual meetings where they do next generation DNA urine testing. If they find a virus, they then use an antiviral. And by using the antiviral, that made the virus go into remission and patients responded well. And that may be one reason why lactoferrin was found to be helpful in reducing lesions and reducing inflammation, because lactoferrin is an antiviral, antibacterial, antifungal. It's a protein that our immune system makes. It's in our tears, it's in our vaginal fluid, it's throughout our body. It is a frontline defense for the human immune system. The challenge is that our lactoferrin levels apparently reduce as we get older. So we have a lot of research now on a lot of different medical conditions of supplementing lactoferrin from cows, primarily, giving that to adults with various human conditions to see if that will boost the human immune system. And it turns out it does. And so lactoferrin has been found helpful for a number of medical conditions. I have a blog on the front page of our website that talks about it. One research team in Italy found that about 4 years ago, found lactoferrin effective for preventing recurring bladder infections. And that same research team did an IC study 3 years later. It was released a year ago, last summer, which found that red inflamed bladders became pink and healthy, and Hunner's lesions virtually disappeared. Again, how? Because lactoferrin boosts your immune system and your body's ability to fight off infection. So given the fact that Hunner's lesion patients have very few options anyway, and given the fact that lactoferrin is entirely natural, it is not a drug, it is obtained from cow's milk, specifically colostrum, and the side effect profile is just outstandingly good for most patients. Patients with Hunner's lesions are now often trying lactoferrin for 5-6 months, just out of curiosity to see if it would be helpful. Some patients are finding it very, very helpful, and some patients haven't, but it's an option now that you could explore. The second cause of a Hunner's lesion may be autoimmune disease. The third cause of a Hunner's lesion may be something far more treatable, which is neuroinflammation. So we had here we go. Peggy said lactoferrin's working for her. There you go. Okay, and I'll get to that. Anyway, so we had a case study of a woman with severe Hunner's lesions who had a severe prolapse. So when they went in to surgically repair the prolapse so that she could urinate, they found something remarkable, that her uterus was facing backwards, that one of the ligaments that normally holds the uterus and vagina in place had broken. So her uterus was free swinging like this. And she had what we would call a torsion injury. You know, this is bad because things are twisting and blood vessels are twisting and nerves are twisting. Very, very bad. What would that then do? That would cause neuroinflammation. So what they did is they untwisted her uterus, they corrected the ligament, sewed her up, sent her home, and something remarkable happened. Her lesions completely disappeared. She is considered a complete and total cure. So that condition is called posterior fornix syndrome. So if you have a history of prolapse, any hip injuries, any ligament laxity, anything at all like that, the uterosacral ligament is the critical ligament because okay, so here, if this is your bladder, right? So let's do it like that. If this is your bladder, nerves come out of your bladder and go up to your spinal cord. Okay, so there's a little fiber of nerves that transition through the tissue that help the bladder communicate with the spinal cord and the brain. The nerve, as it comes out of the bladder, rests on the ligament. The ligament holds it in place. So when that ligament is stretched out, the nerve gets stretched out. When that ligament is broken, the nerve is free swinging. It's not stable. Perfect environment for neuroinflammation. And if you go back, posterior fornix syndrome was identified in 1991. Those researchers very specifically talked about it causing IC symptoms and bladder symptoms. Just the urologist didn't listen. That same research group just not long ago said, hey, this is a phenotype of IC. You have got to assess your IC patients for this ligament issue. Because so again, here's the bladder, here's the nerve. Perfectly healthy bladder, damaged nerve. When that nerve message gets up to the brain, here you got this nerve is firing, help me, help me, help me. But this is a nerve associated with the bladder. Okay. So now the bladder's fine. The nerve is saying, help me, help me, help me. That message is going up your spine to your brain. And your brain's going, must be a bladder problem. Got to be a bladder problem. It's a bladder nerve. But it's not a bladder problem. It's a nerve problem. I'm not explaining that very well, but I read a great paper on it not long ago, and it was fascinating. All right, hold on. Peggy said, lactoferrin's working for me. Been on it since last August. How long do I keep taking it? Help with pain, frequency, pressure, help with my stomach issues. We have about a foot of snow here in New York. Lots of love to you all. Hun, you could gradually reduce the dose and see how you do, or you could stop it for a while, see how you do. And if you start feeling discomfort, you could start it again. I mean, we don't have an answer to that. You could just go on a very low dose, or you could just stop it and see how you do. Anne says, can I put topical estrogen near the rectum? Probably, but that's a good question for your doctor. I don't see any reason to put it directly on the anus, but you can put it on the skin. I mean, it's gonna, if you're putting it on your vulva, if you're putting it on your vulva's, fairly close. And I have said that I too have struggled with rectal pain, but I have now since learned that most of that rectal pain's actually from my pelvic floor. And when I slide my fingers down my butt crack, for lack of a better term, and I get close, I'm never touching my rectum. I'm actually about an inch, an inch away in the glute muscles. They're always tender. So I now recognize rectal pain as kind of one of the first symptoms that my pelvic floor is kind of getting too tight. It's quite interesting. Dawn says, I've tried everything for the last 10 years, been in a bad flare for weeks. Considering a hydrodistension, I've been doing PT, but the pain is out of control. All right, so Dawn, tell us about the pain. Is the pain inside of your body, or is it on the skin on the outside of your body? That's question number one. Question number two, where is it? Is it centered? Is it to the left or to the right? Those are the first questions that I would ask you if you were on the phone with me. Laura said, that's so interesting. Good. Christy said, in my case, I have celiac. Once on a gluten-free diet, it cleared up. Okay. And preparation H wipes, you got to try them. Or Proctofoam. Talk to your doctor about Proctofoam. Proctofoam. Proctofoam was great for painful, itchy hemorrhoids. All right, so Dawn said her pain is inside center. Dawn, I'm glad you answered. Now I can rapid fire you with questions. Is it in your vagina, in your urethra, or in your bladder? Where is that pain? Vagina, urethra, or bladder? All right, you guys on YouTube, you're being pretty quiet. Okay, Dawn, when is the pain the worst? Before you pee, while you're peeing, or after you're done peeing? When is your pain the worst? Before you urinate, while you're urinating, or after you're done urinating? Before, during, or after? These are trick questions. Okay, the pain is constant. So urination doesn't make it better at all? Does it get better for a minute or two and then come back? Or is it just constant all the time? It's the same level of pain no matter what you're doing. Okay, so the pain doesn't vary at all. Okay, describe the quality of the pain. Is it sharp, like a razor blade? Or is it electrical, like you're being zapped? Or is it an ache? Is it sharp, like a razor blade? Is it electrical, like you're being shocked? Or is it dull and achy? Sharp. Pain goes from 1 to 10 daily. Burning. Okay, what then? Okay, let's look at it differently. Are you sleeping through the night? Okay, are you sleeping through the night, or are you getting up all night? Like, can you sleep for 3 or 4 hours? You're not? Okay. How often are you getting up at night? Every hour, every 2 hours, every 15 minutes? How often are you getting up at night? Laura says, I thought for years that I was having female problems because I felt it was vaginal. My gynecologist actually referred me to a urologist who discovered I see with Hunner lesions. The best way that I can describe my pain is like somebody scraping my insides with a wire brush. And Laura, that's an excellent descriptor. And ironically, that's how I described my vulvodynia when I was in high school. That somebody had literally used sandpaper on my skin or a metal brush on my skin. That's real. That's that nerve pain, that neuroinflammation in the skin. Okay, so Dawn can hold it for 2 hours. So her pain is constant. Dawn, what triggers your pain? Like, so let me give you an example. There are a group of patients who, when they wake up in the morning, they're pretty good. But as soon as they sit on the side of their bed, the symptoms start. And then they get worse throughout the day. And then when they lay down to go to bed, it starts to get a little bit better. And they get stuck in this vicious cycle. So, what have you found that triggered your burning? Okay, you say yes. Do you ever feel like you're carrying a bowling ball around in your pelvis? Do you feel like, and often what we see is that it's fine in the morning, but as the day goes on, you get this heavier and heavier weight in your pelvis until it's almost unbearable. And then when you go lay down, it gets better, and generally sleeping is better, but it begins all again the next morning. Okay, sex, food, bending, and the bowling ball. Okay, so my friend, have you ever heard of something called pelvic congestion syndrome? Okay, you say you have pain at bedtime. Okay, but okay, so kind of, it's like you get stuck in this vicious loop. Feel a little, because listen, okay, if you're sleeping every 2 hours, and you're only going to the bathroom every 2 hours, then what that tells me is your bladder wall's not that bad. Because if you had a really severely inflamed bladder wall, you'd be peeing every 10 minutes, every 15 minutes. So the fact that you're sleeping for 2 hours at a time, yeah, it's annoying you're getting up, but it's telling me that your bladder wall integrity might not be as bad as you think it could be. That sensation of, and it's so funny because, man, going back, I mean, I started my support group in 1994. I've been doing this a long time. And from day one, we had patients who said, I feel like there's something in my pelvis. It feels like there's a bowling ball. There's a heaviness. And it gets worse as the day goes on. And of course, then you get diagnosed with IC and you do all the bladder therapies, but it doesn't do a damn thing for it. Because pelvic congestion syndrome is essentially a big varicose vein in your pelvis that's collecting blood throughout the day. And you need to be screened for that, because that bowling ball sensation, that is not an IC symptom. It's not. That is a pelvic congestion syndrome. So let me spell this out for you. You need to Google this. Oh, here, hold on. Wait a second. Why did that come up? Pelvic syndrome. No, okay, hold on. It keeps trying to put a link in there. Okay, pelvic congestion, just put the word syndrome after that. So starting about 4 or 5 years ago, they started bringing in experts in circulation to the pelvic pain meetings to talk very specifically about how disruptions of circulation can also trigger some of the symptoms that we associate with IC. So if it were your bladder wall, you would have pain as your bladder fills with urine that is relieved by urination. That is the hallmark symptom of a bladder wall problem. You do not have that. Your pain is consistent. There's not a lot of variation between full bladder and empty bladder. Okay, so that kind of rules out a bladder wall issue for you, honey. At least we have to be receptive to the fact that other things can be causing that symptom. Also, burning is not a symptom that we associate with the bladder wall as much as we associate it with nerves that are being compressed or irritated. And if you have pelvic congestion syndrome, these big blood vessels would push on nerves, potentially causing that, and or muscles that are working really hard. We also see burning in patients who have severe pelvic floor dysfunction because muscles that are working hard build up lactic acid and that burns. The third thing that we're going to look for in a burning sensation is estrogen atrophy. Dry skin can burn. We call it urine burn. If your urine feels hot as it's coming out of you, that's estrogen atrophy of your vulva. Your urine is not hot and burning you. It's just your skin lacks the defenses it needs to protect itself from that urine, aka estrogen atrophy. So, what can you do for relief? I don't know right now because we don't know really what's causing that burning. You're going to have to follow the basic IC stuff for now. Modify your diet, get rid of the acids, just out of curiosity. Oh, okay. So you started vaginal estrogen. Good. When did you start it? Recently? And how old are you, hun? Just give me a decade. You don't have to give me the full year. Just give me a decade. Are you in your 50s, 60s, 70s, 80s? Where are you? What's the oldest patient I've worked with? I've worked with patients in their mid-90s. And I worked with one who was like 93, like last week. And she was so, man, you would never have guessed she was 93. I thought I was talking with a 30-year-old. She was all there and smart as a whip. Wow. Okay, so you're 62 in 3 weeks. Okay, so estrogen atrophy is real. I'm 65. And estrogen atrophy often first affects the urethra. You might feel like there's a drop of urine stuck in your urethra that won't come out. Estrogen atrophy in the vagina, it certainly causes a lot of burning and discomfort in your vagina. And it has the potential of causing burning and discomfort in your bladder. Atrophy is real. It just is real. And so it's really good that you're on the estrogen. What did the doctor say about your skin health? Did he or she say you've got moderate atrophy, severe atrophy? What'd they say to you when they prescribed that for you? Christina said, is lactoferrin effective? Yeah, it is for many. Not for everybody, but for some patients, and including somebody who was just in the chat who was taking it. It's doing quite here. And now Facebook isn't letting me scroll. Here, Peggy. Peggy says it's working for her. A number. So when the lactoferrin study came out, I just had surgery, so I had to sit on it for a couple of months because I was dealing with cancer and all that sort of stuff, which was awful. And then when I was finally starting to feel better, I did a deep dive into the research, and I've got a big blog on our website with all the research. You can go look at it. Then we found lactoferrin from Australia, which is where the researchers themselves got their lactoferrin. And I think one of the reasons why is that the dairy industry, which is where lactoferrin comes from, is very protected and pristine in Australia. Unlike America, where we have a lot of bird flu and other stuff like that. And the first person who called me had only been taking it 3 weeks. And she said, Jill, you're not going to believe it. And I'm like, all right, what happened? She goes, hey, I can sleep 3 hours now. She said, I haven't slept 3 hours in a decade on 3 weeks of lactoferrin. And she'd just taken a 2-hour car ride and hadn't had to use the bathroom once. She was ecstatic. ecstatic. Now, I've had other patients who have tried it for a couple months and it didn't help. It didn't do anything for them. But at least it's an option because we don't have a lot of options. And the safety profile is really, really good because it's natural. I mean, it's like literally from cows, cow milk. So might be worth a shot. Go over to the IC Network website, icnetwork.org. And right on the front page is a blog on lactoferrin. I have links to all the research. You can look at it yourself, see if you're comfortable with it. And if it is, we've got lactoferrin you can try. There's a lot of lactoferrin on the market now. Lactoferrin can go for pennies on the dollar all the way up to hundreds of dollars. And that's all about the source. You don't want cheap lactoferrin because we don't know where that's coming from. And you don't want the super expensive. I mean, real, genuine human lactoferrin that they've isolated from human colostrum would cost hundreds and hundreds of dollars. The best source for lactoferrin right now is from cows. There is some bioidentical lactoferrin made in a lab. They're calling it, one company at least claims it's human, but you look at the label, it's like, no, it's bioidentical. It's made in the lab. It might match human DNA, human lactoferrin, but it's not real human lactoferrin. It's made in a lab. So, just you get what you pay for. Okay. Angela said it flared me slightly, might work for others. Okay. Good feedback. Dawn says her skin was good. Okay. So again, Dawn, the bowling ball sensation is a pelvic congestion syndrome symptom. It would be, so, you are an anatomical mystery to be solved. Obviously, I'm guessing, everybody's guessing right now. I think it's a reasonable, informed guess based upon your symptom. And I want you to, read about it. And I think it would be reasonable to go to your gynecologist and, are there any signs of prolapse, anything else that might, create that heaviness there? Then they might send you to an interventional radiologist just to see if you might have this pelvic congestion syndrome. It's very easily treated. Don says, pain stays for weeks, then settles. The foods flare you. Yeah, but the bladder wall can be vulnerable for any number of reasons. If you've got a lot of neuroinflammation from pelvic congestion syndrome, the nerves in your bladder are going to be sensitive too. But the hallmark symptom of a bladder wall gag layer problem is pain as the bladder fills with urine that goes away when you pee because urine is no longer touching the wound. So here, let me give you a picture. So think about it this way. Okay, let's use this picture because this is a lot of these are what we call petechial hemorrhaging. This is what happens when you stretch the bladder. So we once thought this was IC. Turns out this is not specific for IC at all. And this has been thrown out in our national guidelines as being meaningful. Okay, but that said, if your bladder wall was wounded, okay, so let's use this one. And as your bladder fills with urine, urine is now going into all those wounds. So the fuller you get, the worse you feel. And then, bam, you pee, urine is no longer on the wound, and you feel better. That is the hallmark bladder wall symptom. You don't have that symptom. Your pain is steady. So now we have to think about why would your nerve pain be steady? So number one, you have been diagnosed at some point in time with estrogen atrophy. That could be it. But you're having a few other symptoms which open the door to other possibilities. That heavy sensation is a pelvic congestion syndrome symptom. That is not an IC symptom. And that burning that's a wishy-washy symptom, because we can see the burning with tight pelvic floor muscles and we can see the burning with estrogen atrophy. Have you had a pelvic floor assessment? What have they said with your pelvic floor? All right, and so we have been going for 2 hours here so far. I am here at your pleasure. Some meetings go 5 hours, some meetings go 90 minutes. It just depends entirely on you. Okay, so your pelvic floor, Dawn says her pelvic floor muscles are tight. Okay, so are you doing therapy? Are you doing proper pelvic floor therapy? That's a finger in your vagina massaging muscles. Okay. How long have you been doing that? So now we have an open door to burning being caused by tight pelvic floor muscles. So how long have you been doing pelvic floor therapy? 7 weeks. Okay, so the question that I want you to ask your physical therapist is, are my muscles responding to therapy, or are they always staying tight? So like for me, no matter what they did, my pelvic floor stayed tight. Left side pelvic floor, always tight. Even today, always tight. Why? So if you have muscles that always lock down into tension, we have to figure that out. And that's when we start looking at bones. So in my case, the reason why my left side pelvic floor is always tight is because my SI joint is unstable and my muscles lock down tight to stabilize the joint. So generally what we see is a dysfunctional hip, a dysfunctional SI joint. Okay, left side for you too. I was a tennis player. I was like number one on my college tennis team, and I played professionally for a couple of years before that's how I paid my way through school. Not knowing that I'm right-handed, and when you're a tennis player and you're right-handed, you step in on your left side, and then you put all your weight on your left hip, and then you rotate as you hit the damn ball. And what that does is that tweaks the joint over and over and over again. And so that is a common racket sports injury. My physical therapist was the physical therapist for the U.S. Olympic team tennis team. And he's like, yeah, that's what you got. I share the same injury as Yvonne Lendl. I wish I were that good. I wasn't. I wasn't that good. Not even close. Okay. So could it be an SI joint? Could it be a broken tailbone? Could you have a funky knee? Are you limping? One of the things a physical therapist is supposed to do is watch you walk down a hallway. You have to walk down a hallway. So I went through, starting in my late 30s, I started having pain when sitting. So like when I first started the IC network, I could work at this computer for 10 hours, which I frequently did because I was writing so much about IC and building our website from scratch. And then all of a sudden it got harder to sit, more painful to sit. And so I went from, 10 hours to 6 hours, and then to 4 hours, and then to 2 hours, and then to an hour. And then in my, by my mid to late 30s, I could only sit for an hour and I couldn't play my computer games. I had terrible pain on my left side, and And then it progressed. And I got to a point, maybe 10 years ago where I couldn't sit for 10 minutes. I could never have done this meeting comfortably. Yeah, I've been sitting here for 2 hours. My left hip is vibrating, but I can sit. So anyway, the physical therapists that I was seeing, they're all saying, "Oh, it's an old muscle issue. You got an old torn muscle here. You just need to stretch." So I stretched like hell, and finally, they just said, "We can't help you. You need to go to a sports physical therapist." And that's when I had no idea who was the Olympic coach. I saw him, and he had me walk down a hallway. Like, first thing he did is just walk down the hallway for me. So I walked down the hallway. He goes, you don't even walk in a straight line. And I'm like, yes, I do. He goes, no, you don't. He said, you walk in arcs. You walk like this. You favor one side. Do you notice that? And I'm like, no, I have no idea. He goes, do it again. He goes, no, you're definitely favoring. Your right side is carrying all the weight. Your left side's hardly carrying any weight at all. And anyway, he's the one who figured out that all the stretching I did was terrible, and that it turned out it was an SI problem, and I needed to strengthen the muscle rather than stretch out the muscle. And when we strengthen the muscle, I could sit again. Okay, so you're having issues sitting. Aha! And you had a hysterectomy just like I did. Definitely made it worse. And endometriosis. I did not have endometriosis. So, you've got stuff. There are so many things that you can do right now to narrow this down. So ask the physical therapist, are my muscles responding to therapy, or are they always tight? And if they are, where? If you're always, the reason why I ask patients, where's your pain? Is it centered to the left or right? And you said centered, but no, you have issues on your left side too. Anytime you have pain away from center, we have to look at muscles and ligaments and nerves and stuff like that. So ask the physical therapist, are my muscles responding or not? If they're not, we need to take a step back a little bit and start looking at how your bones, and maybe you got an SI issue like I do. I don't know, maybe. The fact that you have pain when sitting, does the pain when you sit gets better when you stand up? That's an important question. Does your pain when you're sitting get better when you stand up? We are waiting for her to respond. And you guys on YouTube, you're being very, very quiet, my friends. So for those of you who just came in, this is a support group meeting for men and women with pelvic pain. It gets a little bit better when you stand back up. Okay, so anytime your pain is positional like that, moving your body in a certain body position changes and attenuates your pain, that's not organ pain. That's muscle, ligament, nerve stuff going on. So it's putting you right. Again, there's something going on. C. Sterling said, you're listening carefully. So many similar issues. I learn new things every week. Oh, I'm glad to help. So do I, believe it or not. So do I. That's why I whenever these big conferences and courses, doctor courses come out, man, I'm all over it with a 10-foot pole. I want to learn as much as I can because so much has changed. Everything has changed about how we work with IC. So much has changed, and it's good. Next week, I think we're going to talk about all the gynecological conditions that are associated with IC for the ladies out there. But listen, a lot of men get this too. So for the men, we hear you also. We talked a little bit about men's issues last week too. All right. So Dawn, I don't think you've had the full diagnostic assessment. Yes, they found atrophy. Great. Glad you're treating that. but I want you to kind of dive into the structures of your pelvis a little bit more. And I would strongly recommend that you get this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. This is our pelvic floor injury Bible. And you said you had some trauma in childhood. If it was physical trauma, this would really help you understand how an injured tailbone, how an injured muscle, nerve, etc., would be the underlying cause of your symptoms today. And if you want to call me, feel free to call me. I'm always happy to. And by the way, this book is written for men and women. There are diagrams for men and diagrams for women. This is not a women's book. This is a fantastic resource for anybody struggling with IC and pelvic floor dysfunction. You got it. Excellent. Love it. So the chapter that talks about the feet, I think, is the most revealing chapter of all, because it turns out one reason why your muscles may be tight is because of the way your foot hits the ground. And what became the enduring mystery of Dr. Weiss's, the latter part of his career, is why do muscles stay tight? You know, if you had the pleasure of seeing him in clinic, he was the first urologist to embrace the pelvic floor as an underlying cause. An incredibly humble man. I met him several times. I was a support group leader here in Northern California. Many of our members went and saw him. It will be to my eternal regret that I never got to see him as a patient. I saw him more professionally than I did personally. I regret that immensely now that we know I am a pelvic floor patient. And he became a master at massage and massaging muscles and trigger points and things like that. And so, you know, if you walked in with tight muscles, I can guarantee you would have walked out of that clinic feeling much, much better, because he was so good. And again, we had many, many testimonials from his patients who reported how thorough he was and how experienced he was. And he was. I heard him speak many times. He's a wonderful, skilled man. But what baffled him is that a patient would call back a month later and say, it's back. And they'd come back in and the exact same muscle would be tight and the exact same trigger point, the exact same location would be back. And it's like, wait, we have this all massaged out. Why would it come back? And he talks in this book, he said, that's when we start looking at bones, because what puts abnormal stress and pressure on muscles, dysfunctional bones, like scoliosis, you know, or having one leg longer than the other. Your hips are supposed to be level, but you got one leg longer than the other, bam. And see, when you're a kid, your body's resilient. Your body can compensate for having a tilted pelvis. But wear and tear sets in your 30s, and all of a sudden, your body's saying, help me, there's a problem. So anyway, you know, he started looking at the tailbone and the hips and the SI and all that sort of stuff, and the knees. And he went around the world and he learned from everybody. Again, very, very humble guy. He would be the last person to say, I am the penultimate expert. And it was actually a podiatrist who changed his practice, because the podiatrist is the one who taught him how dysfunctional forces in the feet and how the foot hits the ground get directed right back up the legs into the pelvis, where that will cause long-term tension and wear and tear. So like my right leg is about a 1/4 inch shorter than my left leg. So I have a little 1/4 inch thing in my right shoe, just like an extra Dr. Scholl's footbed. And it was amazing how helpful that was. I thought that was fascinating. Or if you have Morton's toe or Morton's neuroma. And of course, we can't be wearing any high heels anymore, man. I wear Hokas. Every day, all day, I wear my Hoka Bondis. And if I'm not wearing my Hoka Bondis, I'm wearing these. I've got them in white and light blue and black. And that's because I need padding. I can't walk on anything hard. I just can't. I have no fat pads on my feet anymore because of all the sports that I did. I'm literally walking on muscle and nerve. So I have to wear very, very cushioned shoes to be comfortable. So, again, when I started this meeting, we talked about, self-help and basic foundational issues. And we have to address things that, we did when we were younger that might not be so helpful when we're older. And one of the things that women did when we're younger is we wore really high heels, and we can't do that now. That messes up the pelvic floor badly. It just does. I mean, walking like this, come on. Yikes. I can't even imagine what that would do over time. And I will say, I get really frustrated when I see, the Princess Kate, who I adore, but she's always wearing really high heels. It's like, we don't need to do that anymore. Just show kids they don't have to wear high heels to be fancy. They can wear flats, and it's much healthier in the long run. Anyway, it's just a thought. How are you guys doing? For those of you, okay. So C. Sterling says, check out the UFO slides. I love them. For men and women, have my whole family in these now, and they all love them. Hold on a second. Let me look at them. Man, I'm always looking for things. UFOs recovery footwear. Are they super soft and cushy? Oh, I see them. They look very similar. Yeah. They just have to have a lot of give for me. A lot of give. They can't be firm at all. They have to be pretty soft for me to be able to wear them over time. Oh, they say it's like walking on clouds. I will check them out. One shoe every move. Well, and they're not as expensive as Hoka's, so that's good but still, these are more slides. They're not really workout shoes, right? Well, no, they have some shoes. Oh, and they have boots. Ooh, UFOs. Oh, well, the shoes are expensive, just like the Hoka's are. So, all right, I will check them out. Nice. What are the boots? Let's see what the boots are. Ooh, love them. Love the style. Yeah, money. Times are very strange right now. Some companies that I would normally buy chair cushions from, they don't even respond to email or phone calls. It is a very strange economic time right now, because there are some people who say the economy is great, but I'm telling you, at my end, trying to buy product, all the prices are up. The shipping is massively up. And I think some companies are going out of business. I don't know. I just don't know. So I just want you to know that I'm doing everything that I can, because the IC network, now listen, I was never intending to have a store. Never. When first 15 years of the IC network, or 10 years, I paid for everything. It was free. Everything was free. And then, I used up all my savings. I wasn't working much because of my IC, and I realized, okay, we had to have an income stream. Somebody said be a nonprofit. Well, I actually had served on the board of several nonprofits, and I did a fund development assessment. There was nothing there. There was no money there. There's no way we would survive as a nonprofit. All the grant money went to the ICA. There was no room for another nonprofit that worked with IC. So one of our members said, just be a health education company. I'm like, oh, that's perfect. We do that. And then So we started writing books, and then Rob Muldren wrote his first book, The IC Survival Guide, and that's kind of how our store started, was selling his book. And then we were selling cushions and heating pads and restroom supplies and stuff like that. And paid the bills, paid the bills. Didn't pay me much, but it paid the bills. That was good. And then I had a patient call me who had InterStim. And she was in Colorado. And her doctor told her the only treatment for IC is InterStim. And so she had surgery that failed horrifically for her. Didn't work, and she had complications. And so she called me. She finally heard about the patient groups and called me, and she didn't even know about diet. She knew nothing. This doctor just so said, I'm going to treat you with InterStim, and that was it. And I was shocked. She hadn't been offered any oral meds. She hadn't been offered anything but surgery. And this giant light bulb turned on, and it was like, wait a second. Patients need a place to come where they can see options, that there are options other than surgery. And that's when the supplements started. And so we had Pre-Leaf, which is the most well-known supplement of all. It reduces acid in urine. It helps you eat food that might be acidic. I mean, that's been out for 38 years, something like that. It's the most well-known supplement out there. So I called them, became friends with the CEO. They ended up sponsoring the IC network, and we brought on Pre-Leaf, and then I became friends with the CEO of Desert Harvest at the time, Pat. We brought on that, and then we brought on a couple of other ones, and the reason why I'm saying that is that we all have to understand that the treatment options for IC are really limited and really expensive. A lot of people simply cannot afford Botox. They cannot afford bladder installations. They cannot afford traditional meds. They just can't. And they can't afford to have a hydrodistension or anything at all like that. And so the question is, what do they do? Well, now we at least have a few things that they can try, like some supplements. And if they don't work, hopefully we can get them back to the doctor, and the doctor can do a proper diagnostic workup. Let's see if that patient has pelvic floor dysfunction. Let's see if that patient has Hunner's lesions. But supplements are important now. They have fewer side effects, and that's what the AUA says. That's not me. That's the American Urology Association in their guidelines. Encourage patients to try over-the-counter nutraceuticals because they come with fewer risks of adverse events than traditional meds like Elmeron. So supplements have become important for many patients. C. Sterling said, try the slide to start. The sole will be the same in almost all their shoes. Okay. The beach is my happy place. Oh my God. I love your username. My brain wants me to go sit on a warm beach for a year. On December 26th, you had Botox in your bladder. First time in 3 years, you've had more than 2 free pain days in a row. Only problem is urethral burning cyclically, even after full hysterectomy. You did physical therapy until Botox. Did the urethral burning start after the Botox? Or have you had urethral burning consistently this whole time? All right, you guys on Facebook, you're being a little quiet. Give me questions. I mean, when we're done, we're done. That's fine. We'll all go do things. But I know there's some of you who've got 3 feet of snow and you got nothing else to do. So feel free to give me questions. And just so you know, on YouTube, you guys are on a 2-second posting delay. It's supposed to be 2 seconds. If it's longer than that, let me know. I try not to have to put that on there, but sometimes I have to put the delay. Hold on. I'm wondering if I can turn that off. Ah, there you go. Just turned it off. Excellent. So you should be able to type right away. Johanna says, I live in Ohio. It's still snowing. She said, I think the cold weather gives me a flare up too. It would. It would. Any temperature extreme is stressful on your body. And with cold, what your muscles do and what your core does is everything, your body starts to divert blood supply in some way. And I'm not sure which direction, though. What direction would the blood supply go? I think the blood supply would leave your fingers and your feet and head to your core to protect your heart and stuff like that in periods of very, very intense cold weather. And yeah, I mean, listen, I sleep with a heating pad every night. Okay, back in 1980, so the beach is my happy place says no, back in 1987. So urethral pain, there are several things that we look for with urethral pain. We look for pelvic floor tension, specifically in the levator ani muscles, which wrap around the urethra. If you've got a urethral stricture, if you can't release urine easily, like if you cannot pee like a horse, that literally you're trickling out, that's a sign that you have a urethral stricture, which is a sign that you have pelvic floor muscles that could be squeezing your urethra. We would look also at it, potentially a pudendal nerve irritation from tight muscle that can affect the urethra. We would look for skin irritation from chemicals, anything from laundry detergent to fabric softener to God forbid, bubble bath, which is a big no. Soaps. One of the worst flares I've ever had was from Irish Spring. My boyfriend at the time did a bubble bath for me. This back in Ohio. God bless his soul. He's gone now. He was so proud of himself. I was sitting in his living room and he was in the bathroom. I had no idea who was making a bubble bath for me. And I walked in. He goes, yeah, come in. I did something for you. And I got this overwhelming smell of Irish Spring. And he had made a bubble bath with liquid Irish Spring soap. And I looked at that and I looked at him and I was like, oh no, what do I do? I don't want to hurt him. He tried so hard to help. And I'm like, thank you, honey. And then I thought, okay, I can sit in this for a couple of minutes. Oh, horrible choice. I had to get on a plane and fly back to California. I cried for 6 hours straight on the plane and in the drive home because I was burning so badly from that Irish Spring. Oh my God. And what was crazy is my mom decided to surprise me and she took the bus down to the airport and met me at the airport. And as soon as I saw her, I started crying. I mean, the flight attendants, everybody's worried about me. I was just crying in my seat the whole time. And it was just Irish Spring. Oh my God, I'll never forget that. You tried, Matt. You tried. It just didn't work. It just didn't work. We want to look at, and then we would look at neuralgias, and we would also look for, is there any, so like we had one client who always had terrible urethral pain. She'd been to 5, 6, 7 doctors. Everybody diagnosed her with IC. And they kept ignoring her urethral symptoms. She finally went to another doctor and actually saw a nurse practitioner. And she's like, it's my urethra. It's my urethra. And the nurse practitioner said, let's do some imaging. And what she had was a pocket off of her urethra that was like, so here's your urethra. She had a pocket connected by a little tiny tube that was almost the length of her urethra that was filled with fluid, filled with urine. That was her urethral pain. And when they went in surgically and repaired it, completely healed. So you got to be the squeaky wheel when it comes to urethral pain, and they've got to look at a bunch of different things. While the Voss is away, says, I've been using Preleaf for several days, and it definitely does help. It helps by reducing acid in urine. It doesn't repair the bladder wall. It kind of just protects the bladder wall from acid-induced irritation. So just, you don't eat it like candy, okay? You just use it before a meal if you're eating something acidic. Because it is calcium. And if you eat a lot of calcium, the calcium's got to go somewhere. And if you're prone to kidney stones, it could potentiate the growth of kidney stones. So just be normal and modest. Preleaf has the best brand recognition out there, and I see it. Excellent safety profile. And that company also now has a new product called Peleaf, Pealief, which is a palmitoyl ethanolamide supplement designed to calm nerves down. It's like Peora, but it's called Peleaf. And that's gaining a lot of traction for them now. The Beach is My Happy Place said, my pain started from birth control back in 87. Okay. Also started the Vagifem in April and the estradiol patch in October. You have atrophy too. They found a tight spot, 10 o'clock, when they worked on it, pain for 3 to 4 days, had a pudendal nerve block, and a trigger point injection. Okay, well, they found a trigger point. There you go. So you're probably going to be doing, you might be like me. You might be, because my symptoms started in 1973 when I was 13. I had all urinary symptoms. They said I had bladder issues for decades. The only symptom is I had a urethral stricture. I felt like I was peeing through a needle, but they ignored that. They kept saying infection, and then eventually they said IC. But in the end, now we know what it was. My bladder was always normal when they looked in my bladder. There was never redness, inflammation in my bladder at all. It was my muscles. When the pelvic floor research came out and I went and saw a physical therapist, my muscles were as hard as a rock. Because I'd broken my tailbone when I was 13. I had been in pelvic floor dysfunction from the time I broke my tailbone. And here, hold on. I mean, here's the thing you got to understand here. All it takes is one bad fall on your tailbone to set this off. And that could have happened in childhood. And we've got a lot of patients who over time, some patients cannot have an internal exam. Literally, their muscles are so tight, the doctor can't even get a finger, much less a speculum, inside their vagina. And there are patients out there who have never had pain-free sex. Their muscles are so tight, bam. That's called vaginismus. And so the question is, what causes that in the first place? And for many patients, it's physical trauma. God knows, think about it. God forbid you were a gymnast or an ice skater or a baseball player where you slid into home base. I mean, all those are pelvic traumas. If you jammed your crotch on the bar of a bicycle even once, that's a direct trauma to the pelvic floor and to the nerves in the pelvic floor. And that creates the foundation for pelvic floor dysfunction over time. And the challenge here is the symptoms are frequency, urgency, pressure, pain. You're going bladder, bladder, bladder. But you do the bladder therapies and you don't get better. Why? Because fundamentally the bladder is being victimized by poor blood supply from tight muscles and compromised nerves. But getting back to the tailbone here, here's the thing you got to understand about the tailbone. So here it is, right? Sacrum, hip bones, sacrum, tailbone. The tailbone doesn't just hang there. The tailbone is an anchor point for muscles. It is the foundation, structural foundation of the pelvic floor. And so if you fell on this tailbone and it healed out of position, now your muscles are skewed. Your tailbone hangs down and under like this, right? But if you broke your tailbone, maybe your tailbone's sticking out like this, or maybe your tailbone's skewed to one side. That's all going to tweak your pelvic floor badly. So we see a lot of tailbone injuries now triggering this entire cascade of IC symptoms. Hi, Larissa. Good night to you too. Sherry, hello. Diane, hello. Sandra said, I have the worst flare since 2011. So, Sandra, call me this week and let's talk about it. Johanna said, I would love for my urogyno to listen to you. Actually, I did some lectures for the International Continence Society and their pelvic pain. I was invited to do that by Dr. Elise Day with several other doctors, and they have now created this big course with all these videos we did. I think I did mine 2 years ago. When did I do mine? When did I think I did mine 2 years ago, right before we found the cancer. Yeah, because I remember telling them that I had cancer. Yeah. Oh, life. Diane said, if you keep 200 the daily recommended calcium intake per pre-leaf, would it be okay? I would assume so. Their daily recommended guidelines are that's what you follow. I mean, it's up to the company. The company has to establish safe use. So follow the company's recommendations. And, I always err on going a little bit less than that. I always look for the least amount that I can take. So I personally rarely take maximum doses of anything. I always go for the lowest effective dose. The Beach is My Happy Place said, hydrodistension showed long relations over 30 to 50% of my bladder. Botox had the bladder pain calmed. Just that cyclic urethral pain I'm trying to figure out. Okay, so lung relations have been thrown out because we now know the test itself causes them. Okay, so our guidelines that were updated 2 years ago say that. Glomerations are not meaningful to the diagnosis of IC now at all. They're not unique to IC. We think that's a residue of what happens when you do a hydrodistension. It's interesting that the Botox calmed your bladder. Cyclic urethral pain. So what's the cycle? What's the cycle? I mean, is it daily? I mean, explain that a little bit, hon. C. Sterling says, when I sit at my computer, I sit on a neck pillow with the opening under my tailbone. Good move. It really helps prevent pain, not a donut shape, but the U shape. So there's a gap for the tailbone. I am sitting on this. Right? Groove down the middle. Each butt cheek supported, but nothing pushing up. Unfortunately, the company, it does not appear to be functioning right now. They have ignored all of our emails, all of our phone calls for several months. So I can't get them for you right now. I'm sorry. I don't think they're being made. It sucks. I mean, let me check my email. Let me just see if by miracle on miracles, she responded. Here, hold on a second. No. I sent an email on December 11th, sent an email on January 15th. Last time I heard from them was October 1st. So I've tried to order. I just cannot get them. I'm sorry. Well, they were being hit really badly by the tariffs. But, the tariffs technically have been suspended, but that doesn't mean that the companies out there aren't using this as an opportunity to make a little bit more money by raising prices. You got to understand that despite what certain people have said about tariffs, the price of tariffs inevitably get passed down to the customer. If I had to buy something from Australia, as I have done regularly, they, and they have to pay a tariff. Well, they're going to raise the price of their product by that amount of that tariff. I mean, they're not going to absorb that. They're going to increase the price to me. And then when that comes to me and now I'm paying 25% more, I'm going to have to raise the price to you 25% so that I don't go belly up, Tariffs are a lot of misinformation about tariffs. The beach is my happy place. Said, even though I had a full hysterectomy, it's the week before and the day off of what would be ovulation and 2 or 3 days before when I would have had my period. Do you still have your ovaries? I mean, was it a total hysterectomy or did they leave an ovary or two? Melissa said, thank you for this. I'm sorry I did fall asleep because I didn't sleep much last night, but would love to read. You'll be able to listen to it again on Facebook, and Facebook only stores it for a month. You can come over to our YouTube channel and rewatch it on YouTube. Facebook is where most people, like 5,000 people on Facebook, watched it last week. Over a period of a week, where only a couple hundred on YouTube watch it, but that's okay. I'm just being a support group leader. The YouTube channel is youtube.com/ICN Jill. There you go. All right, so we've been going for 2 hours and 40 minutes so far. I am happy to stay and take any question you have, but when you slow down, you slow down. For anybody out there who doesn't want to talk publicly, you're always welcome to contact the IC Network privately. Our phone number, which is actually on that sign right there that you can't see. There's our phone number, 800-928-7496. It's on the top of our webpage. If you want to reach out to me by email, it's icnetwork@mac.com. We have WhatsApp. You're welcome to call. You're welcome to reach out and just be the squeaky wheel, my friend. If you don't hear from me, try again. Just keep trying until you hear from me. I work on a first come, first served basis every day. Some days I'm on the phone 7 hours a day and then my voice gives out and I have to stop. Other days I'm writing all day. So if you get my message, when you call, you're going to come to this cell phone. And if I'm working with somebody, I'm going to reply, can I call you later? And then when I'm free, I will call you. Okay. But just, you got to be patient, because sometimes I'm working with patients who are really struggling and crying, and I can't I got to finish them before I can take another call. Okay, so you had a full hysterectomy, and yet you flare a week before and the days off. It's strange. You also had a prolapse repaired. You're describing an estrogen-induced flare the day that you ovulate and a couple of days before what would have been your period. But honey, you had a hysterectomy a long time ago. How would you even know when your period would happen? Well, you know what I would do if I were you? Because you're describing a hormone flare. I wonder if they left an ovary in. Could they have taken one ovary and not another? Number one, understand, I totally believe you. I would never question you. I mean, this is your life. This is your experience. These are your symptoms. I am not doubting you at all. I believe those symptoms are happening. Now we just have to figure out why. Because those are hormone driven. If it's one day and then 2 weeks later, 2.5 weeks later, you have a 2 or 3 day flare, and then 2 weeks later, you have a 1 day flare, and then 2 weeks later, you have a 2 or 3 day flare, and you can map it out on a calendar like that, man, that really sounds like a hormone flare. That sounds like an ovulation and that sounds like an ovulation flare. And so you don't say how old you are. Understand. I think I'd want to look at the surgical report again, to be quite honest, because that's very, very, very unusual. And I've never had anybody in over 30 years explain that the way you explain that. And again, I'm not doubting you at all. I totally believe that this is happening. It's suggestive of a hormone producer. Okay, you're putting it on your calendar. So you should, if I were you, I would talk to your gynecologist and say, this doesn't make any sense to me. Like, I'm flaring like I'm ovulating. I'm flaring like I'm having periods, but I had a hysterectomy. Can you make sure that can you look at that report? Is there any chance that I still have an ovary? I don't know. I will say that there are a number of patients who have surgery and they don't know really what happened in that surgery. Okay. And you say that's what I was thinking. The report shows that both were taking. Well, you say maybe you had an extra one. I don't know. It's baffling. The only other thing, so the female body, when you go through menopause and your ovaries have stopped producing estrogen, where does the female body store estrogen? In fat. That's why we get a tummy. I mean, that abdominal fat becomes a place where the female body stores estrogen. Yeah. That is just, I mean, the report says they took 2, but man, I think I'd do a sonogram and just out of curiosity, see if that report was true. Surgical errors happen. I mean, they can do it. They've got sonograms in their office. They can just whip out a sonogram and, put it over your belly just out of curiosity to see if there is something there. Because that's weird. Yeah, I agree. It is weird. Chimera says 2 weeks ago, and the doctor didn't like that I was on the edge of being too low for my calcium, potassium? Is there a guide on trying to keep the levels of these things in a happy place for your IC and your doctors? Just Google it. There's no independent data that says IC patients should get this amount of calcium. It's just every doctor relies on the normal levels recommended by various medical associations, not the FDA, but medical associations. So here, let's just do that right now. Let's see. How much calcium should an adult woman consume daily? Let's see what that is. If you're between the ages of 19 and 50, it's 1,000 milligrams a day. If you're between the ages of 51 and older, it's 1,200 milligrams a day. The maximum daily limit should not exceed 2,000 a day from food and or supplements. There you go. The upper limit is 2,000. Some people might say 2,500. And here's somebody at National Institutes of Health says even lower amounts. So World Health Organization says 500 milligrams of calcium a day. No, they say 1,200 milligrams a day. No, wait, that's Harvard. That's not the World Health Organization. The Beach says, I'm definitely overweight now too. Could it be like a muscle memory or phantom pain? No. Well, no, let me take that back. I don't know how you would be going through cyclical hormone variations. That because you don't have ovaries anymore. And unless you were on like birth control pills where you're on for 2 weeks and then off for a week and whatever, I can't see any other way that would happen unless I just don't know. I honestly just don't know. But muscle memory is real. If you got tight pelvic floor muscles, you can still have tight pelvic floor muscles now. And phantom pain wouldn't be cyclical, but phantom pain is real. Neurologic pain is real. Diane says, it's the Lyris device. That's the name, Lyris. It's the Lyris device used for Hunner's lesion treatment now. I saw an article on the IC Network page of a study that showed it reduced the number of lesions. It did, but what happened is a big medical device company bought it. They bought it and they stopped using it for IC. It's long gone. They bought it. I don't know if they shelved it or there were so many applications for Lyris, specifically in chemotherapy for bladder cancer and also for antibiotics. I assumed that they bought it for that use, but it's dead in the water for IC, which is tragic. So the Lyris device was what I was talking about earlier. Imagine a small tube filled with medicine that's put inside your bladder where it slowly releases medicine for a 2-week period. And again, the fundamental flaw with trying to treat a bladder disease is, number one, if you swallow it, does it get to the bladder to be helpful? The answer is no. Bioavailability tends to be very low for bladder wall issues. For oral bladder medication issues for the bladder wall. If you put the bladder treatment directly in the bladder, which is the best way to do it, the problem is you pee it out. You can't keep medicine in the bladder because you pee. and so keeping medicine in the bladder consistently over time is very difficult. So these researchers in Massachusetts, I forget the name of the company, I know the CEO flew out and met with me actually, created the lidocaine pretzel that they called Lyris. So it was a specific polymer type tube, and then when you put it in the bladder, it twisted so that it wouldn't come back out. And so it delivered time release medication into the bladder, specifically lidocaine. And then 2 weeks later, they would put little forceps up your urethra, grab the tip of it and pull it out. And the early data for that was really, really encouraging, because some doctors reported that Hunner's lesions healed. And so everybody got really, really excited about that. And then I think they did another round of study. I don't remember what that was. And then this other company bought it. But think about it this way. If numbing the bladder all the time made the lesions go away, maybe the lesions were caused by an irritated nerve. And if you calm the nerve down with lidocaine, I don't know. Anyway, but then other doctors had an argument as to why that wasn't true. So good question. The beach is my happy place says, was thinking my pain cycle has been relatively the same since 1987. So maybe my body brain possibly used that pattern. Thanks so much for helping me brainstorm. I think you need a proper phenotyping, honey. You should call me this week. Let's talk. I'd love to talk to you about it because I think it's really fascinating. Generally, with a patient who's had symptoms for so long, again, we weren't phenotyping back then. If I were to guess, I think you probably have an old pelvic injury. I think that there's probably an old persistent injury in there that's causing a lot of this for you. But call me, we should chat. I mean, that's a guess. My job is to educate you, inform you, give you a new set of questions, send you back to your doctor with a new set of questions. Obviously, I do not give medical advice. I'm an educator. Johanna said, what's a WhatsApp number? Good. I think it's, what phone is it on? I got to figure out what phone I put it on. Is it on this phone or... is it on this phone? Let me look. Okay, it's not on that phone. So hold on a second. Where on earth did I put it? Obviously, we don't use it that much. Oh, here it is. Okay, so it's on this phone. ICN Jill. ICN Jill, I guess. I'm not a WhatsApp expert here. I can answer the phone, but it's over on the contact page on the IC Network website. Sorry, I should know this. All right, guys, listen, I think we're done. So to anybody going through this, know I wish you the best. I truly wish you the best, and be safe, stay warm, get those pets in, help each other, be kind and comforting to everybody, because life is very weird right now. That's for sure. All right, guys. I'm going to go make dinner and watch the next Landman episode because Billy Bob Thornton is insanely good. I really like watching him. All right. I'm going to say goodbye to Facebook first. Goodbye, Facebook. All right. Facebook is done. All right, you guys on YouTube. I wish you well. Have a good one. I'll see you next week.